I mean, it is interesting, right? That like we were living out in the woods for so many years and we were really accustomed to like being isolated and
Hello, beloved
isolated and at home
survivors.
and be pelted with
I'm Autumn
blizzards,
Brown,
rain,
and
heavy
this
rain,
is
and
How
even
to
awful,
Survive the End of the World,
intense snow
a podcast
storm.
about learning from
Oh, trust me,
apocalypse with grace, rigor,
we all
and
know how to fight a
curiosity.
fire.
The other voice you're
Um,
hearing is my eldest child, Finn.
However, so one time, in science class, for the warm up we actually did something called, what 10 things would you, bring onto a deserted island?
As the
Ooh.
series has
It's
unfolded,
large enough to
one of the
store all
emergent
kinds of life,
themes is the
palm trees,
necessity of
lives in spring
adaptation
water,
under
like a mountain, which is like
apocalyptic conditions.
an extinct volcano or like
As
whatever.
our reality
It's like there's plenty of
changes, or
resources,
as our
and
reality is unveiled to
you equip
us,
a bunch of items.
we must iterate on how we have practiced and what we have built so that we can build new practices and the new worlds that are necessary for our survival. As the pandemic unveils the reality of healthcare in this country and the violence of what healing justice activist Kara Page refers to as the disease economy, we are confronted with the need to adapt how healthcare is delivered. But even more than that, we are confronted with the need to rewrite the very assumptions that underpin this system, that the body is a commodity, that health is a product, and that some lives are disposable, whereas others are worthy of extraordinary measures to save. The models of care delivery here in the US can feel monolithically bad, but part of my political work over the last 15 years has been in service of connecting and uplifting the alternative economies of care and alternative practices that already exist. I didn't have to look too far to find the right person to have this conversation with. I'm grateful to welcome Dr. Anjali Taneja to the show. Anjali is a family physician and a DJ who is passionate about reimagining healthcare and healing in the US. She is board certified in family medicine and addiction medicine. She's also the executive director of Casa de Salud in Albuquerque, New Mexico. And she works in the emergency room of a small rural hospital in the Navajo Nation. From 2007 to 2013, Anjali curated Cure This, which was an online community space for discussion around new models of care. I remember reading her work before I met her. I finally met Anjali in 2010, shortly after she served as a lead coordinating member of the People's Movement Assembly for Healing Justice and Liberation at the US Social Forum in Detroit. She also oversaw the medic response team of volunteers at that event, which was attended by over 18,000 people. Now, a bit about Casa de Salud. Casa de Salud is a clinic. It's a culturally humble and anti-racist nonprofit model of care clinic that integrates primary care, queer and transgender care, harm reduction, addiction treatment, acupuncture, Reiki, massage, and indigenous-based healing circles for uninsured, immigrant, and other marginalized communities in Albuquerque. The clinic also trains 30 health apprentices a year, who are primarily young students of color interested in healing and healthcare fields, and prepares them for careers in health and healing. I'm really excited to introduce Anjali and to introduce Casa to our listeners. You're going to hear a lot more about Casa de Salud's model and history in the interview. So let's jump right in.
The story of our organization is pretty fascinating and is very much the reason why I wanted to join it. I was not part of the founding team, but back in the early 2000s, there was a group called the Community Coalition for Healthcare Access, or CCHA, that was working to respond to gaps in care and gaps in access to care and a number of other issues on the ground that um, community members, residents, patients, practitioners saw as critical. At the time, in the early 2000s, fully 25%, or one out of every four residents in New Mexico, did not have health insurance.
Mm.
That percentage is not very different from where folks in a lot of other states were pre-Affordable Care Act. And healthcare institutions, though doing critically important work, and I always have to say, staffed by amazing healthcare providers at every level of expertise and service, were existed in a way that created gaps in various areas, including, I'll talk about this, including around cultural humility, including around
Mm.
financial access and transparency, including around what gatekeeping created, language access and interpretation, kind of the industry of healthcare and the way
Right.
time is rationed, for care, the way race and racism play a role, and the way healthcare institutions create barriers inadvertently to care.
Mm.
And then
Mhm.
healthcare workers are plugging into those institutions and sometimes know about and sometimes really don't know about a lot of the um, barriers and problems that perhaps exist in their institutions.
Mm.
So at that time, a group of organizations, patients, community health workers, healthcare providers were taking a 10-step process to asking the safety net hospital, which was University of New Mexico Hospital, to make changes on the way that they provided care for folks who had traditionally been marginalized from society and from
Anjali,
healthcare.
can you just explain what you mean when you say a 10-step process?
Oh, back in the early 2000s, there was a demand, a list of 10 demands that related to the issues that I noted around language access, financial transparency, relief of medical debt burdens, other different things that were being asked of the local healthcare systems.
Mm.
And in that process, there was also a move to create a system that better responded to the needs of the community. And at that time, in the South Valley of Albuquerque, which is culturally rich and diverse, with a number of populations of folks who've been there for generations, as well as more recent immigrants, many Spanish speaking families, that had South Valley of Albuquerque also was part of a trade route for heroin and other drugs, and a lot of folks were dealing with intergenerational traumas and intergenerational drug use
Mm.
in the South Valley. Also, a ton of industrial and environmental injustices in that area that no doubt contributed to people's livelihoods and their incidence of chronic medical conditions.
Right.
And
Right.
then a paucity of healthcare services, their behavioral health, mental health, um, healthcare, as compared to the rest of the county. And all of that was represented in the fact that there are parts of the South Valley that have a 15-year decrease in life expectancy compared to the rest of the county that Albuquerque
Holy
sits in.
shit. Wow.
So because of all of that, there was a move to create a clinic that was able to address, fill this gap, as well as rebuild trust with the community. A lot of folks don't necessarily interact with healthcare systems because there's a lack of trust,
Mm.
based in years of feeling cast aside or needs
Mm.
not being met, or racism or inability to work with people from a trauma informed process, things like that. So health promoters, promotoras, traditional healers, Western medical clinicians came together to create what was called at the time Topacal,
Hmm.
Family Medical Office. And so Topacal was a part of, was adjacent to, on the land of the Calpuli Iskali, traditional Mexican healers' work and
Hmm.
collaboration. So on the front of the land was the Calpuli Iskali, made up of traditional women healers providing a range of healing practices. There was a sweat lodge, and then behind that, a 3 or 4 room casita got converted into a small walk-in clinic that could
Wow.
that first of all, the walk-in aspect was a critical access piece, because if you called clinics in the area at that time, there would be 2 to 3 month waiting list without a lot of ability for walk-in care. So meeting the needs immediately in that
Mhm.
way, as well as a financial structure that best responded to community needs. It was $25 for a visit, pay if you can, and only pay at the end of the visit. So you get your care first, and then you make the decisions about payment. No
Wow.
bills sent to people's homes, no people's accounts that went to collections. We are not in the business of increasing um, emotional and financial burden on patients who are struggling with things. So
Mhm.
it was pretty popular and integrated Western medical care with clinicians who were passionate about nutrition, exercise, integrating with other healers in a way that was respectful and understanding. Like, for example, I'm a physician, I'm a family doc, and I don't try to do acupuncture or do herbal medicine, but I have great
Mhm.
respect for my colleagues in those areas who've trained in those areas. And so, therefore, I partner with them to provide care in the same place.
Right.
Um, and I see that as critically important because there's a lot of folks who are trying, I'll do a little bit of acupuncture, learn a little bit. Like, why not we just partner with people who are experts in their medicine and work together
Like,
in a
how about
coordinated
yeah.
way. Yeah, so that was built. All the practitioners spoke Spanish. Um, a walk-in clinic that was available also on evenings, which is critical. Most of the clinics in the area did, and to a great extent still do, only provide care during 8 a.m. to 5 p.m. business hours. And a lot of
Wow.
people work, and it becomes challenging to get care when you need to. So we immediately off the bat, had evening hours, had Saturday hours, things like that. And so it was a place where people could rebuild trust with healthcare, and they could get referred in from a healer that they were seeing in the community, or they could find out about it otherwise by word of mouth. It was all word of mouth information, and it became a pretty busy walk-in clinic. We did all kinds of procedures, women's health, physical health, integrating different types of medicines. There was a naturopathic doctor on board, acupuncture, Reiki, curanderismo, with one of the founding clinicians at the clinic, who is currently at the clinic, who's a nurse practitioner and a curandera, a traditional Mexican healer.
Wow.
All of these were provided and integrated, and people could self-select into which of these they wanted to uh, receive, and also be in a place where they knew that everyone was really on the same page and spent the amount of time with each patient that needed to be spent. So a lot of
Mm.
people's experience with going to the doctor is they have 10 minutes, they're on their computer typing in things that people are saying, because those 10 minutes include the visit with the patient and any charting that needs to be done before the next patient is ready. We have
Right.
a
Right.
spacious, expansive amount of time with patients, 30 minutes, sometimes more, up to an hour, for Western medical care. And then obviously some of the other modalities are, straight up 1 hour or more. So that was a walk-in clinic setup that became pretty popular. It was very accessible. People could get care, rebuild trust with healthcare, and it became popular enough that neighbors were like, "What's going on?" And after a couple of years, we moved to the building that we're currently in, and then in
Mm.
2013, we doubled the size of the building that we're currently in. And
Wow.
we currently have um, employed staff, all employed staff with benefits, who are a range of, among the clinicians, who include doctors, nurse practitioners, physician assistants, nurses, as well as a doctor of Oriental medicine, who's our acupuncturist, a Reiki master, who's also our ear detox specialist, another modality, and two massage therapists, and a curandera. So we have all of these folks on staff who work together in the same space, working as a clinic, not as individual kind of private businesses referring to each other. And so
Oh
that's
my
an
God. So
integral
incredible.
piece of what we
Mhm.
do. And I wish there were more clinics that were doing this work, especially in regards to access to marginalized communities, because it feels so important to work on mind, body, soul, trauma, all of these things from this perspective, and to rebuild trust with communities. So I'll just mention our clinic right now is we primarily work with marginalized communities, but we're open to everybody, and lots of different folks come access our care, millennials, all over the place. But
Mhm.
primarily we are serving low income folks, monolingual Spanish speaking patients, recent immigrants, queer and transgender residents in the county, and honestly beyond. I just saw a trans patient who comes to us from 100 miles away to get care,
Wow.
um, as well as folks who are people who are using drugs who access our syringe exchange services, so they can bring
Mhm.
in their used syringes and exchange them for new ones, and to be able to shoot safer as they are injecting, but also get education about doing so, and to gently have nudges and openness around the ability to get treatment if they're ready or want to. And then
Mhm.
we have a pretty robust, very integrated opioid addictions treatment program at our clinic that integrates all the modalities together, along with evidence-based medication treatment, and comes from a harm reduction frame, which I'll talk a little bit more about. Um, but that's our model of care. And on the finance, so 80% of our 75 to 80% of our patients currently do not have health insurance.
Yeah,
So
I was just gonna ask whether well, I had like 2 questions, and
yeah,
it sounds like you're going there, but I was gonna ask, one, if the passing of the Affordable Care Act in any way, shifted the way the financial part of your model worked, if it helped at all, or if it
yeah,
created new barriers or, new challenges? And then I was gonna ask, just, out of interest, how you all are able to finance your operations
sure.
given the access model that you're working with.
Absolutely. So, yeah, so I mentioned that before the Affordable Care Act, fully 25% of New Mexicans did not have access to health insurance, which is extremely challenging, and where healthcare systems had financial discounts, but for a lot of people, those prices were still extremely prohibitive. And
Right.
also back then in 2004, part of the work that was the year we started, part of the work we were doing was trying to hold our safety net hospital accountable, because they were charging patients 50% upfront for non-emergency surgeries.
Oh my
And a
god.
non-emergency surgery is, I can't walk, I need a hip replacement for a hip that has been debilitating pain wise, and has not allowed me to work for the last several years. And my orthopedic surgeon says that this is critical. It's not, I'm in a trauma, I'm in a car accident, I need emergency surgery, but it's a critical surgery. I would
Still,
have had to
yeah.
pay like $15,000 up front before I could get the surgery and then pay the rest off in a period of time. And so our coalition at that time pushed really hard against that, and over time was able to reverse that, which is critical for
Wow.
the safety net hospital in our community, which is tasked and has federal funding and state funding to really provide care for low income folks.
It's just
So
baffling to me that that is a process that was unfolding at the safety net hospital. That is
it
just mind-boggling.
absolutely, yeah, yes, yeah, in a state which, there's only three main hospital systems in a large catchment area. We're a urban rural state, of 2 million people, with a lot of low income folks in the whole state, and a lot of need. So we great question about the ACA. So when the Affordable Care Act passed, we were so grateful that our Republican governor was one of the first governors to expand Medicaid. As you
Mm.
probably know, a number of states in the Southeast still in 2020 have not expanded Medicaid as part of
Right.
the ACA.
Like refuse to do so, right?
Refuse to do so, are
Mhm.
actively fighting against it even now in the midst of COVID-19, when that can only benefit both hospitals and the state, because the feds are still paying more than 90% of all costs associated with expanding Medicaid.
Wow.
And at the time in 2011 or so, 2012, feds were going to pay 100%. So our Republican governor was one of the few Republican governors who immediately worked to expand access to Medicaid. And we are a state right now that has a significant proportion of our patients accessing Medicaid. Like I said, we're a poorer state.
Mhm.
We have, about 40% of our population in New Mexico has Medicaid. So at that time, we started working to accept Medicaid. These were exactly the same patients that we had had before, who now
Mhm.
had access to this um, state Medicaid program.
Right.
And so over the last number of years, we've been working to expand access. And so we now see still 75% to 80% of our patients being uninsured. And then the remainder 20 to 25% are patients who have Medicaid. And that number is expanding
Mhm.
at our clinic. So we primarily see those two groups, meaning groups of patients who fall into the uninsured and Medicaid group. And we've contracted with Medicaid is just amazing. They don't have to pay a copay. They don't have to ever
Right.
pay a copay. They don't have to pay for their meds. We don't believe in copays. We don't like this idea of people having insurance, but then still having to have another transaction of money at their primary care clinic or the hospital or wherever. And
Mm.
so we can still hold that value and accept Medicaid and provide care for people for free. And some of that money is going to subsidize the care that we do that is not reimbursed, care for uninsured folks and care in the integrative healing modalities that we provide. We're
Right.
fighting for, but we don't have in New Mexico the ability for acupuncture to be reimbursed by Medicaid, and then Reiki and massage are not reimbursed by
Right.
Medicaid. So,
Right.
so those are our two patient populations. And then financially, like you were asking, we're as an organization really passionate about having a sustainable business model that is not a free clinic model where we would be depending on rich white people to make the organization function.
Mm.
And that is not a model where people are having to dig deep into their pockets or, you know, uh, deal with a lot of other huge administrative burdens of working with a lot of insurances or things like that. So
Mhm.
we kind of have a one third, one third, one third piece. We've one third of our income is revenue generation from patients paying their bills, which each visit right now is $40 with a practitioner.
Mhm.
And we have some significant county funds, which we're grateful for, to help subsidize that care or make that care entirely free. So it's kind of a
Mm.
sliding scale model where a majority of people will pay the $40, and then some people won't, and that's upfront. That people
Yeah.
don't have to. And then our Medicaid revenue is fairly decent. Medicaid pays probably twice or more than twice what a self-paid discount cost of care is for patient
Mhm.
care. So
Mhm.
that helps us take care of everybody. And then one third of our income is from um, grants and individual donations, and then one third of our income is from contracts that we have with the county, the city, the state to provide critical services like syringe exchange, which I talked about, which we
Yeah.
want to do all in one space so that people have this like one place, respectful, dignified, friendly place to go,
Mhm.
where they can get all different kinds of services and opt in to any of them. Nothing is mandated.
We will be back with more of my conversation with Anjali in a moment, but first, an offering. So many of us have lost beloveds to COVID-19, and so many of us will. And we are creating a space to honor those losses here on the podcast. In the final episode of the series, we will read aloud the names of those who have been lost. So if you wish to send the name of a loved one for us to read out loud, please email it to us at howtosurvivepod@gmail.com. Please do include guidance on how to correctly pronounce your loved one's name. Grieving together is part of how we survive and how we remember life. We hope you will let us hold a part of your grief. Okay, back to my conversation with Anjali. This show, this podcast is about apocalypse and survival, obviously. And our whole, the whole theory that kind of underpins the way we have conversations on this show is the idea that it is communities most marginalized under capitalism, under white supremacy, under patriarchy, under all of these systems. It is the communities that are already surviving these systems that have the most to teach us about how to survive conditions of collapse. And I was wondering if you could speak to, I mean, you already teed this up in terms of talking about the various healthcare practices and some of the indigenous healing practices that are already integrated into your clinic. But I was wondering if you could speak a little bit more on what practices were already circulating in the communities that come to you as patients that you then integrated into the clinic space, and some gems from your experience working collaboratively with patients who are to some extent guiding their own care.
Sure, absolutely. So we built this space in part because we wanted to better respond to how people were currently accessing care, what which kind of healers and support networks they felt supported by, they accessed, and how to build, a Western medical piece around that. So the modalities that we currently offer for healing are informed by learning from patients who they went to, and obviously our partnership with Kalpuli Iskali in 2004 meant that a lot of community who were accessing curanderismo and a number of other modalities with the Kalpuli and otherwise were saying, "Oh, I need this other care too, and this is amazing. This is happening right here." We are friends and colleagues with the Kalpuli Iskali now, but back in 2007, when the move happened to the building where we are right now, the two, Topakal at that time and Kalpuli, kind of split and are still very close to each other. And we transformed into Casa de Salud and gave them the name Topakal out of respect.
Oh, beautiful.
So we still work with the Kalpuli, and they've done workshops on with community members with us around gardening and around creating your own medicine through food and a number of other things. And we refer patients to each other, and we're maybe a mile away from each other still.
Wow, that's so cool.
But all of that informed how we built the modalities that we have. We've also been doing harm reduction work since 2005, since the first year of our time as a small 3-room casita turned clinic in the South Valley. And we are so grateful to the State Department of Health, who has been, New Mexico was at the forefront of responding to the opioid crisis and dealt with significant intergenerational drug use and heroin for probably generations before the 90s, when pharmaceutical companies are implicated in creating and worsening the opioid drug epidemic. Like, this existed for many prior years in New Mexico, and that often gets erased. There's like a starting point of when the crisis happened. And so that was another gap that we saw. Like, their healthcare institutions are not, doctors, nurses are not right now well positioned to respond in a non-stigmatizing way to folks who are using drugs, or they are, but the institutions in which they work in are not, or drug users have some trust issues with large healthcare and how they'll work with them or how they'll treat with them. So we had built that immediately, and so for the last 15 years we've had a pretty robust syringe exchange, Narcan distribution for overdose prevention, as well as having the works, being able to educate people and provide some tools around how they can use drugs more safely so that they can reduce transmission of HIV, hepatitis C, skin infections,
Mm-hmm.
harm to themselves through other kind of overwhelming infections. And perhaps also with this idea of dignity and partnering with our community, many folks will want to pursue treatment and have some other abilities and function different functions in their lives. So with that, we understood very quickly that people would come to us and bring a lot of syringes, and we would give them a lot of syringes, and they would distribute those out to peer networks of folks. So there was already this somewhat self-organized way of supporting each other and bringing syringes and getting new syringes for a number of folks in the community to use.
Yeah.
And so teaching people who were bringing those to us about shooting safer and other things were ways in which that they then passed on to other folks. We also have our healing circles, which are indigenous based, 2 to 3 hour long circles at our clinic with a curandera and our Reiki master and Iraqi detox specialist, and holding space and having a sacred feather in indigenous tradition where one person is speaking, that person is holding the feather, and only that person is speaking, and everyone's listening, and that feather is passed around. There's a theme and deep talk around shame or something else, another topic, and then a variety of healing modalities, including a limpia or a traditional Mexican cleansing, Iraqi detox, and Reiki that is provided to patients to be able to relax, cleanse out feelings and everything that they kind of talked about or shared that may have been hard that day. And
Wow.
the formation of that and how we offer that has been informed greatly by our patients. And the entire way in which we do our treatment program for people who are using opioids is based on feedback that we have gotten from patients about what's working, what's not working. We had a lot of
Wow.
folks first starting, and then we had kind of a set of mandatory things that folks would do to get through the first phase and then go from there. And a lot of people struggled with that and dropped off. And so we have flipped our entire program based on what people are telling us either verbally or through their actions,
Mm-hmm.
um, to have a low barrier access point to get in. Someone says, I'm looking for Suboxone, I'm ready to stop heroin. We can provide that day, next day, within a week, and then build around the other services around them and have healing modalities and therapy and other things that are opt-in to them. So giving them that decision-making power, which doesn't happen a lot in treatment programs around
Right.
the country. There's this
Right.
prescribed way that each place has. And those are part of the harm reduction modalities with principles. Mary Hawk and others specifically wrote out harm reduction principles and broke it down. And we utilize these in every aspect of the work that we do. And that includes things like, autonomy, and, we can negotiate care with patients instead of having a paternalistic way of treating them. Humanism, that's the dignity. Pragmatism, like we don't come from an abstinence only model. People can
Right.
use multiple drugs and we can still treat them for their heroin use and then use that space to build trust and dignity to then support them on their meth use and support them on treatment for hepatitis C or their physical health or emotional health issues. And an accountability without termination, that's a whole huge piece of harm reduction where we're going to work with you. We're going to treat you with dignity. We'll hold you accountable to things and really ask you to go deep with some things, but we're not going to kick you out. We don't have a three
Mm.
strikes law where you have three quote unquote dirty urines and you're kicked out of our program. So those are programmatic related, but very much are infused through the way that we do our work with the clinic. And I'll say
Wow.
one more thing because I'm talking a lot,
Mm-hmm.
but
No, I love
we,
it.
we,
I'm like
we,
taking notes.
we with our community, we are trying to see healthcare differently, and we're trying to connect with other organizations around the country, um, to really build more of this thinking and how we do it. We are not a federally qualified health center. We don't get money from the feds to do our work. And we have intentionally chosen to be an independent nonprofit health center instead of an FQHC for a variety of reasons that relate to, the kind of administrative burden and largesse that needs to happen with FQHCs, the ability for us to provide care in a way that integrates all modalities and that's nimble and doesn't have a lot of bureaucracy. All of those things that's a whole other conversation we could get into. But
Mm.
one thing that we're afforded in our model is the ability to think about healthcare differently outside of the clinic setting. So we want to, like, we feel like we'll die trying. We don't know if we'll get there, but we are aiming to build power with our community. And what does it mean for a health care clinic or institution of any sort or size to build power with community? Not just I'm giving you healthcare, but
Right.
your leader, you have survived X or Y or Z, or you're brilliant. How do we partner with community to do things differently? And we've done that over the years. Again, we'll die trying. There's lots of ways that we can criticize what we've done or we haven't gotten to where we want to, but this is a journey for us and something that we're committed to doing as a small institution that is situated in community. We've built some really strong relationships with community agencies, with neighborhood groups, things like that. And
Mhm.
with our patients, we've taken issues like overwhelming medical debt that they may get from hospitals, in the thousands of dollars, and work from a direct service place of let's help you navigate that debt of this is how we deal with this collections agency, or this is how we get, a little bit more help from this hospital, or this is how you can advocate for yourself. And over a number of years, helped Bernalillo County residents decrease their overwhelming financial debt from hospitals by over $2 million.
Wow. Wow. Holy shit.
Which is about $2.5 million at this point, probably in the last 4 or 5 years. And we're continuing to do that kind of direct service work, but also we built a patient coalition around folks who are trained up in media skills to be able to advocate. Some of the first folks who helped build the clinic were people who were patients who became activated and fought for changes in the safety net hospital and how they did their billing. And in the last year, 2 years, we've done a couple other things with folks in our addictions treatment program. We intentionally call people leaders when they come in instead of the idea that they would be treated and kind of re-traumatized with ideas of shame coming from a clinic.
Right.
And we've built out kind of this vision and implemented popular education workshops around how folks who are using drugs or who are in treatment can teach other folks in the community about the history of the drug war, resilience,
Mm.
how trauma acts on our bodies, things like that, and activate them to help make change, work on advocacy issues, work on systems change issues. Because so many people are like, I'm coming out the other side of my recovery and I want to help people in
Right.
a more impactful
Right.
way who are just
Right.
starting out. And we recently implemented a leadership survey, primarily among our harm reduction, our syringe exchange clients, but also among our patients who were in treatment, to get a better sense of what kinds of leadership activities are they currently involved in, because we don't want to make the assumption that they're not,
Yeah, they're
and
not. Right.
what are they looking for in the future. And now we're seeking some funding and partnerships to think about how we can partner with community members, meet them at whatever level they are, and work on leadership development and community change with them.
Wow.
Um,
And it is, I mean, everything you're describing is, I mean, it's so visionary and it's also, it sounds like incredibly difficult work because you're you're inviting people into leadership and decision making over a type of institution that um in most contexts for most people with a US healthcare experience, like healthcare institutions are completely opaque in terms of how decisions are made, in terms of what guides decision making and who even is in control or has the power to make decisions. So it's just like, it's just amazing to hear. And I can imagine like the challenges, also just like the individual interpersonal, the
yes.
yeah, the challenges of of making that invitation, meeting that invitation, and really adapting to what people say they actually want. And so I just want to say, like, I commend you all so much for the work that you're doing. And it actually, I mean, you keep like teeing up my next question so beautifully, because this, what you just shared for me feels like a really good segue into having a conversation about this current moment in medical care and some of the assumptions that underlie how we access care. And so the first thing I wanted to ask you is, from your perspective as a medical practitioner, as a doctor, I wonder what you think the current pandemic unfolding has unveiled about our medical systems and how they operate, or perhaps even some of the assumptions that underlie how people typically access care, that, you know, maybe wasn't widely understood or known before, but is really, really obvious now.
Yeah. Gosh, that's a big question.
Sorry.
No, okay. Yeah. So COVID-19 is definitely revealing, for many of us, the fractures that exist in our healthcare infrastructure. And for many others, it's not revealing anything. This is what their experience has been,
Right.
with healthcare. There's so much to say here. One, we don't really have any kind of coordinated on the ground infrastructure in healthcare. And there's a million ways that we need to respond to what's going on. Healthcare is one piece, so I'm talking mainly about that piece. But there's no coordinated way of responding to pandemics, and we see that right now with what's happening at the federal level, and how the CDC has lost funding and has lost a lot of power in how response needs to look like. Public health departments all over the country have had budgets radically cut over the last decade, 2 decades. This is a bipartisan thing. This is not like a current federal government situation. There's been less and less of a priority given to them, which is very short-sighted. And our healthcare system is privatized. I was talking about New Mexicans previously. 25% of them didn't have health insurance. Currently, 11 to 12% still don't have health insurance. And across America, in the Southeast states, Medicaid has not been expanded. Their numbers are, out of control in terms of who does not have easy access. And even having health insurance doesn't necessarily mean easy access to healthcare.
Right.
It's just a financial mechanism. There's this idea right now also with, if you're worried you may have COVID, or if you have these symptoms, go to your doctor, call your doctor. And it's such an archaic idea, because I think most Americans don't have their doctor.
Right. I was just thinking that, like, I don't have a doctor, a quote unquote doctor that's my doctor. And how would I have that? Yeah, exactly.
So this pandemic comes, and it's like, okay, go to your doctor to navigate this. And, people who have their doctor, or to go to a clinic, clinics are overwhelmed. Health systems are overwhelmed. We have privatized healthcare in America, which means each hospital is doing their own thing, and they're doing their own thing based on capitalism, and elective surgeries are what bring in money. So right now that we've stopped elective surgeries in order to preserve personal protective equipment for what's needed for COVID, we're seeing the chance very quickly that hospitals in rural areas, low-income areas, but hospitals in general may go under at a time where we need them the most. The whole way that healthcare providers are being treated in this is the first time that I'm really seeing a place where healthcare workers are unified around one issue. Like, everyone's getting a sense, and I'm not talking about the local clinic level, that's another kind of picture, but in a hospital level, in like large system levels, folks are getting a sense of who's really out to support them and who's not. And we're seeing healthcare workers protest, demonstrate, um, sacrifice when they were not asked to sacrifice in this way, um,
Mm.
not having the most basic personal protective equipment that is needed to not actively get infected and potentially die of COVID-19 while they're trying to support people who need help. And I mean, this is criminal on so many levels.
Mhm.
And the way the supply chain works with personal protective equipment, and even with ICU beds and even with ventilators, or private hospitals, manage out what amount they need to turn a profit. They're not managing out how many ventilators they would need in case of a pandemic. That would not be profitable to them. So that's a whole part of why we have all these issues with the supply chain right now. And then the fact that all of this stuff is coming from more so from other countries than from here. And I'm not even talking about the federal government's participation in the screwiness around the
Right.
criminal activity, I would say, around all of this. But healthcare workers are realizing that they are, in many ways on their own, trying to do this work, and they're seeing their struggle now as tied with the struggle of folks in community in a much deeper way. And I don't
Wow.
mean to assume that healthcare workers are these elitist people who don't care and don't otherwise have an awareness, but there's such a melding of that now, which is stunning, and is not fair to the healthcare workers who are doing this work right now. And
Yes, like, what a moment to be politicized around this. It's like,
exactly,
yeah.
yeah. And the way we're seeing COVID, COVID is a colorblind, wealth blind disease, but obviously in the way that it impacts our community sitting in a capitalist environment, all the capitalism is going to show up and is showing up. So everyone is affected, and the numbers and amounts of people who are dying crosses all socioeconomic levels, all racial and ethnic levels, but the ways in which disproportionate impacts are happening on communities of color, on low-income folks, on folks in congregate settings is just alarming, and reveals the fractures in our ability to support people at various levels. And all of it's so easy to say, oh, a lot of folks who are, or to come to conclusions about why a lot of Black and brown people are dying right now from the virus in
Mhm.
disproportionate numbers. In Chicago, 70% of all people dying in Chicago are Black. In St. Louis, for a while, at least until last week or a little bit before then, every single person who had died in the city was Black. Um,
God.
in Queens, which is an epicenter in New York City, a lot of immigrant communities are being just so greatly impacted, and people dying left and right. And a lot of folks have underlying medical conditions, and it's easy for people to come to conclusions of like, oh, people didn't take care of themselves or didn't trust or whatever else. But the way that underlying medical conditions like heart disease, diabetes, chronic obstructive pulmonary disease, a number of other medical conditions are imprinted on bodies of Black and brown people is because of all of the structural inequalities of
Exactly.
poverty and stress and lack of upward mobility and racism, and the way that racism impacts folks. So we're seeing all this, and I worry about people coming to conclusions about it's already happening. You have a lot of people on the right saying, "Oh, this is just affecting people with multiple medical issues, or people on their last legs anyway," which is so cruel and heartless,
Oh
and is
god.
revealing a lot about a lot of people.
Mhm.
Uh, but our healthcare system was never set up to support low income folks with severe medical issues, and those are the people who are getting impacted the most. And then our economic systems are not set up to support. So we have people, living multi generationally in families or in small apartments with numbers of other people, or the fact that I think 16 less than 20% of Black and brown folks have jobs in which they can isolate at home, while significantly higher proportions of white and Asian folks have that. So all of these ways are revealing the ways that our economic systems and our healthcare systems are working. And then now seeing how many people are dying across the country in nursing homes, and the ways in which that data was not being collected. And now, thanks to states' efforts and local municipalities' efforts, that's starting to be collected. There's never been a plan for how to support nursing homes during a crisis. Like, there's no plan. There's nothing written about that in the
Wow.
past. And then folks in prisons and jails are incredibly susceptible right now. In the medical care in prisons and jails is bad to negligent to start with, and then putting this on
Right.
top of it with people who have to pay for soap and pay copays to see a nurse in the jail is just horrific. So we're basically killing people, for, I think I had mentioned somewhere else that the first person to die in a federal prison in this country was a man who had been in prison for over 20 years for possession of crack. So his death sentence came for something that he shouldn't even have gone to jail for, to
Right.
prison for.
Right.
So all of these ways, and then on a local level, and I'll stop there. On a local level, there isn't really a coordination infrastructure. Like, for example, my clinic, Casa de Salud, is not part of a network of organizations on the ground that in any way communicate with each other. And we could be communicating with, the 30 other clinics, whether they're federally qualified clinics, private for-profit clinics, primary care clinics, free clinics. We could have a pretty sophisticated communication system with them, with the city, with the county. Things are starting to be developed now, but that a healthcare system that is not based in the health of its community, but is based in the profits of the folks running things, creates these dynamics. I could say 15 more things about this, but I will stop there.
Wow. Thank you so much for this just incredible, brilliant.
Thank you.
Thanks for tuning in to the Apocalypse Survival mini-series of how to survive the end of the world. If you want to learn more about the past, present, and future of healthcare through a social justice lens, I invite you to check out a series of conversations Anjali developed in partnership with Kara Page and Susan Raffo on one of our favorite podcasts, Fortification, which is a show hosted by Caitlin Greenlove. Also, Anjali, Kara, and Susan have been developing an interactive historical timeline that explores the medical industrial complex. So you have so much to learn from these three geniuses. You can find Fortification wherever you get your podcasts. We're nearing the end of this series, but we have a couple episodes left to share. Our next episode will feature a conversation on the complex question of arming and protecting ourselves in violent conditions. And our final episode will look at lessons learned from this series as a whole. How to Survive the End of the World is on Twitter and Instagram at End of the World PC. We're also on Facebook at End of the World Show. You can make a sustaining donation to our show by visiting our page at patreon.com/End of the World Show. We kind of can't believe the fact that people are still donating, even in the midst of what's happening in our economy right now. We're so grateful to all of you who are making this show possible. Thank you so much for supporting the work. Another incredibly helpful thing that you can do to help our show sustain itself is to write us a review on Apple Podcasts if you're an iPhone person. Music for today's show comes from Tunde Alaniran and Mother Cyborg. And How to Survive the End of the World is produced and edited by the incomparable Zach Rosen. A fun note about Zach: he just started releasing episodes of a brand new daily podcast that he's producing called The Best Advice Show. I've been listening and it's lovely. A little bit about the show. It's easy to feel helpless as each new day breeds more uncertainty. The Best Advice Show exists as a daily reminder that there are weird, delightful, and effective ways to survive and thrive in this world. In every episode of the show, a different contributor offers their own personal take on what they do to make their life better, healthier, saner, and more livable. Contributors include the poet Hanif Abdurraqib, the journalist Ann Friedman, my sister Adrienne Marie Brown, some dude Zach found on the internet. Also, Zach's wife is on the show, and also possibly you could be on the show. You can find it wherever you listen to your podcasts. We're proud of you, Zach.